Hello, I'm Dr. Curran, and for today's talk, I'm going to discuss dysarthrias with you. So, dysarthrias falls under one of the categories of disorders of speech and language. The other one being aphasias. So, remember, we've already discussed aphasias in our lecture about higher functioning. So, I'm not going to elaborate about aphasias today. We're just going to merely focus on dysarthrias. Okay, so what is the difference between an aphasia and a dysarthria? Remember, I said aphasia is an acquired disorder of language and comprehension and expression, as opposed to dysarthria, which is a disorder of articulation and phonation. So inherently, aphasia is kind of disorder of your language, where dysarthria is a disorder of articulation and phonation. In other words, what a person sounds like. And therefore, we're going to look more into this category today. Okay, so how do we tell dysarthria and aphasia apart from each other, as both are disorders of speech and language? And like I mentioned, a dysarthria is a disorder of articulation, where people sound abnormal. They can still perform all of their normal language functions, but they just have an articulation deficit. So let's quickly look at the qualities of a dysarthria. So dysarthria is an abnormal articulation of sounds or phonemes. And this is due to an abnormal neuromuscular activation of the speech muscles. Therefore, it affects the speed, the strength, the timing, as well as the range and accuracy of movements involving speech. It can typically localize the dysfunction of the CNS, the nerves, as well as the neuromuscular junction or muscles, with the contribution of sensory deficits in some cases. It does not include structural problems. So patients who underwent surgery, who had problems with their palate, tongue, and larynx, this is not a dysarthria. Dysarthria typically affects articulation, phonation, breathing, and prosody of speech. And these are the qualities that we're going to look at when we try to differentiate dysarthrias from each other. So how do we assess a patient with dysarthria? And like in everything else in neurology, as a matter of fact, in medicine, it starts with a patient history. So these are some of the clues that you can look at when you want to try to work up a patient with a dysarthria. So one of the first things that you might ask is, how long has it been going on? Did it happen suddenly? In other words, pointing to something like a brainstem stroke or a stroke in that anterior limb of the internal capsule. Or is it maybe possibly a gradual progression of weakness, maybe pointing to something like motor neuron disease? Another question that you might ask is, how does the pattern of speech change? Does it fluctuate during the course of the day? So maybe better in the mornings when you wake up, and while you're performing activities, you get this fatigability associated with it, maybe pointing to something like myasthenia gravis. Is there any emotional liability to this person with a dysarthria? Emotional liabilities may be pointing to something like a pseudobulbar effect that we see with upper motor neuron dysarthrias. Now, where did the weakness initially start? Did you initially have weakness in the eyes? Maybe also pointing to something like myasthenia gravis. Did the weaknesses start proximally? Maybe the patient complains of having difficulty performing overhead activities, pointing to a myositis. Did the patient have weakness initially in the hands that's now progressively getting worse? Maybe pointing to something like bibrachial weakness or flail arm syndrome, something else that we see with motor neuron disease. Are there any swallowing difficulties or shortness of breath? There's only a couple of conditions where you present with breathing difficulties, myasthenia gravis being one of them in neurology. So let's look at the types of dysarthria. So there are basically 5, maybe 6 types of dysarthria. And the importance here is that you first have to localize the type of dysarthria, and otherwise try to identify what type of dysarthria you're sitting with. And then once you have identified it, you can start working the patient up for the possible causes of this problem. So the first one up in our bucket list is pseudobulbar dysarthria. And this is the upper motor neuron variant of a dysarthria. The second one is bulbar dysarthria. So bulb being the brainstem, and this would cause the lower motor neuron variant. So that would be the nucleus, the cranial nerve nucleus, fascicles, as well as peripheral nerves, neuromuscular junction or muscles. And then we get the ataxic variant of dysarthria. And this would point to a cerebellar disorder. And then we get the hypokinetic as well as the hyperkinetic variants of dysarthria. And this is going to point to a basal ganglia lesion. And then obviously, like everything else, there's the mixed category as well, which can be a combination of any one of these dysarthrias. So let's look at an approach to dysarthria. So there's basically going to be 3 steps that you have to perform when you approach a patient with dysarthria. So in each of these steps that you're going to perform, you're going to try and differentiate whether you're sitting with a pseudobulbar, bulbar, ataxic, hypo, and as well as hyperkinetic variant, even a mixed variant. Then we're going to move on to the second step, where you have to look at whether it's mainly going to help you to differentiate whether it's a pseudobulbar, bulbar, or even a mixed variant. And then step 3 is going to again help you to point and differentiate between all of these 5, even 6 categories of dysarthria. So can you figure out what these 3 steps are without me telling you? So an analogy that I like to use for these 3 steps is similar to the ones the orthopedic surgeons use. So when they approach a fracture or a joint problem, they like to look, feel, move. So instead of looking, we're going to listen to the dysarthria, and then we're going to feel the dysarthria. Yes, we can feel the dysarthria. And then the third step would be to move to the neurological examination. And those are the 3 steps that we're going to go through now into much more depth and detail. So let's look at step 1. So step 1 is going to constitute to listen to our patients. So you have to listen to them. So how do you listen to them? What are you going to ask them to do? So this is where the hint comes in. You have to ask them to perform a tongue twister sentence. Are you going to ask them to perform no, ands, ifs, or buts, like what we mentioned in higher functioning when we approached aphasia patients? No, we're not testing repetition. Repetition is a modality of language. We're not doing that here. We don't care if the person can say that accurately. We want to give them a tongue twister sentence, and by giving a tongue twister sentence, we can try to deduce what type of dysarthria the patient is sitting with. So what are the good tongue twisters that we use? So you can use any one of these following. So you can use the tongue twister 11 benevolent elephants. This is one of the commonly used ones. There's also another one. We can use statistical significance, baby hippopotamus, Methodist Episcopal. This is one of my favorite ones. And then we obviously also use Pitaka, the Pitaka variant. So remember, I mentioned it doesn't matter how well these people can say it. You want them to fail and stumble over these sentences. Because while the person is failing and stumbling over these sentences, the pronunciation becomes much better, and you can hear that articulation and phonation that's happening in these people. Pitaka is particularly useful when you want to try to test that rapid alternating movements of the tongue, the lips, and the soft palate, specifically for cerebellar disorders. Okay, so let's approach our patient with dysarthria and let's listen to them. So remember, this is going to happen after you've asked them to say that tongue twister sentence. So let's say Methodist Episcopal. So let's start off with what a upper motor or a pseudobulbar dysarthria is going to sound like. All right, so they're going to have a spastic and thick quality to it. It's going to be slow and strained, and the voice is going to sound slurry. So all of these dysarthrias are going to sound slurry. The slurriness just means that there's a high overlap between them. And even after you've asked them to say that sentence, that tongue twister sentence, you might still struggle to classify your dysarthria. But no worries, that's the reason why there's a second step. So even if you've got an overlap between the dysarthrias, you're going to move to that second step, and hopefully you'll get some clarity after you examined the patient. That feel step, you felt the dysarthria, and that's where the examination process is going to come in. Okay, so let's get back to the pseudobulbar dysarthria patient. So these patients typically going to sound like they have got a hot potato in their mouth. So we all know what that sounds like. If you've eaten food that's too hot and you try to talk while you've got that hot piece of food in your mouth. So this is what it sounds like, a hot potato. So let's quickly listen to a patient with a hot potato speech pattern.
Hoe is mijn bloeddruk?
Hoe is mijn bloeddruk?
Ik versta je niet.
Nou, ik versta u.
So as you can hear here, this is it's the voice sounds really strained, it's tight and thick and slow in quality. You can hear that the voice is slow when she tries to articulate and phonate, and this is typically what a pseudobulbar dysarthria is going to sound like. But like I say, you might mistake it and call this slurry, because all of these dysarthrias is going to have a slurry component to it. Okay, so let's look at the second type of dysarthria, the bulbar dysarthria. So let's see what this is going to sound like. So these patients have a slurry speech pattern. They have a nasal twang to it. So that's that hypernasality. The reason why this hypernasality occurs is because of this lower motor neuron picture that you have in your cranial nerves that governs articulation and phonation, and therefore the soft palate typically gets affected. And then what happens is that while your soft palate is now flaccid, it doesn't want to close up anymore. So there's a lot of air seeping into the nasal passages, creating that hypernasality component. So we typically like to use the analogy that these patients sound like Donald Duck. So let's quickly have a look at what they sound like.
Okay, so I woke up Saturday morning and I had double vision and blurred vision in my left eye. And when I walk, I have no sense of balance and I need to hold on to something to walk. And it's continuing today, and it's Friday, so almost a week now, and the same symptoms.
So as you can hear, this is our first case, and this patient it's really subtle there, but as you can hear, there's a little bit of a hypernasality to it. There's that nasal twang that's sitting in this patient, but it's really subtle, and you have to listen very carefully in order to hear that. So let's listen to the second case.
Through my eyes, that I can't strain them up tightly, and close them, particularly at night.
So here you definitely hear nasal.
Facial expressions, the face don't move around here. Then it's my tongue, which affects my pronunciation, so it can be difficult to talk. This in turn affects my swallowing, so liquids goes up my nose, and it can affect my
So from my listening to this speech pattern, you can hear very nicely that this person's got a profound nasal twang to it, and this is the hallmark of slurriness. So bulbar dysarthrias sound slurry. It's that flaccid component that sits in, and you get this type of speech pattern. Okay, so let's look at the third type of dysarthria that we get, and this would be the ataxic dysarthria. So these patients have this scanning, atactic, slurry speech pattern with a staccato component. The way to think about this is almost like runner's speech. So what happens here is what happens with staccato is that in this type of speech pattern, while the person is talking and voicing, what happens is that talking and breathing takes coordination, and that's coming from the cerebellum. So when you lose that coordination between talking and breathing, you're going to inhale and exhale at inappropriate intervals, and that's going to create a more explosive strider-like type of speech pattern, and that's the typical one that we see with ataxia. This and that's why it's referred to as runner's speech. So let's quickly let's listen to what one of these patients sound like.
Now,
Yeah.
Russell Wilson,
Why is Russell Wilson your favorite player?
because he's that guy.
And who do you think is the best quarterback of all time?
Joe Montana,
Why is that?
because he was so smart.
Can you repeat after me? Pup, 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 pup.
Ba, 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 ba,
Ta, 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 ta.
ta, 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 ta,
Ka, 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 ka.
ka, 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 ka,
Pataka, pataka, pataka.
ba, 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 ba.
So you can hear here that this patient's got that ataxic faltering speech of pattern, and then it's got that staccato component, and then you can hear that strider picture that we see there as well. And this is going to be the key pathognomic finding in this type of patients. And then we get to the final type of dysarthria, and this would be a mixed dysarthria. So as we can see, a mixed dysarthria can be a combination of any one of these types of dysarthrias, as well as the hypokinetic or ganglionic types of dysarthrias can also be superimposed into this mixture. So let me quickly play for you this dysarthria. You can hear what it sounds like.
Probably about 2, a little bit, maybe 2 years ago.
And then you're a very talkative person. What did people say on the phone? What did they ask?
This is funny. I really like something QVC, and I have to be careful for always something. Oh, I can't understand you. But if you order something over the phone,
So let's try to analyze what we just heard. So as you can see here, or hear here, is that this the quality of her voice is really soft. The voice is lower. There's a little bit of a hypernasality component to it as well, with the superimposed slurriness. But on top of that, you can also hear this straining quality to it and slowness. So this hypernasality would be in keeping with a bulbar component, and then that slowness would be that pseudobulbar component. And this was a patient that was diagnosed with motor neuron disease, and that has this combination of bulbar and pseudobulbar dysarthria. But as you can hear, it's quite difficult to make this up, or to analyze this voice pattern. So this is where the second step now comes into play, and that's going to hopefully help to clarify what type of dysarthria you're sitting with. So just to take one step back, if you remember where the second step fits into the big picture, with our first step, we first try to listen to our patients. We ask them a tongue twister question, and then we try to analyze it by looking at the pattern of dysarthria that we sat with. Now with the second step, we're going to examine the patient. So we're going to examine those specific cranial nerves before moving on to the third step. So which cranial nerves are we going to examine? And those would be the cranial nerves that governs articulation and phonation. So these specific cranial nerves would be cranial nerve 5, 7, 9, 10, and 12. And while you examine these cranial nerves, you're going to assess for upper as well as lower motor neuron features in each of them. So you're going to assess for that pseudobulbar or bulbar components in each of these cranial nerves. So I'm going to discuss each of these cranial nerves separately. Okay, so let's start with cranial nerve 5, the trigeminal nerve. So we're going to assess for the upper as well as lower motor neuron findings. So let's start with the upper motor neuron findings, or those pseudobulbar findings. So in here, we're going to assess for the jaw jerk as well as the cornomandibular reflex. So remember, this is now in the presence of a dysarthria. In other words, this person has got weakness in their muscles that governs articulation and phonation. So a jaw jerk is going to help to point you to what type of dysarthria we're sitting with. An isolated jaw jerk on its own, So if you've got a brisk jaw jerk on its own, but you don't have a dysarthria, there's no relevance of that. But in the presence of a dysarthria, if the person is weak, that jaw jerk is now going to help you to assess whether it's an upper or lower motor neuron finding. So let's quickly have a look at what a jaw jerk looks like. So this is a person with jaw clonus. So you can see this person's got sustained clonus of the jaw. Okay, so let's look at the corneomandibular reflex and what does that signify. So I'm going to start playing this video. So while you can see this, so while he's touching the cornea, we can look at the part of the mouth that twitches as well, and that would be the corneomandibular reflex. So typically we see this in patients who are comatose and who have subsequently sustained hypoxic brain damage. So you typically only will see this in an ICU setting. So let's see what happens in a bulbar or lower motor neuron dysarthria. Okay, so what will the trigeminal nerve reveal when we examine a patient with this finding? So here we're going to see the reverse of a brisk jaw jerk. You're going to see an absent jaw reflex. And then there also might be atrophy. So remember, don't fall into the trap to say that there's going to be atrophy on one side of the face. No. You're going to see atrophy that governs the muscles of mastication. So which muscles will you see this? You might see it in the temporalis, as well as the masseters, or even the pterygoids. You won't be able to see the pterygoids, so you'll only find that jaw deviation to one side. Okay, so technically the temporalis muscles are the ones that's going to reveal atrophy. So we're not going to see in the other muscles of facial expression. That's innervated by the 7th cranial nerve. And remember also, atrophy is a feature of long-standing dysarthria. So you hardly ever see this in a patient with a dysarthria, where you will come in and where the patient will come in and you expect to find atrophy. It hardly ever happens. So the main thing that you're going to examine when you examine the trigeminal nerve is to assess for that absent jaw reflex. Okay, so let's examine the next cranial nerve, and that would be the 7th cranial nerve or the facial nerve. So if you remember from our brainstem lecture, we're going to either examine for a central or a peripheral facial nerve palsy. So with a central facial nerve palsy, you're going to have forehead sparing, remember, because of the bicortical innervation of the frontalis muscle. You might find those mimetic response. So remember, if you've got a patient with an upper motor neuron 7, the emotional component is spared. Therefore, you'll have a mimetic response. So your patient won't be able to overcome this volitionally, but emotionally, the lower half of the face is going to be overcome. And then you can expect to find frontal release signs. So what are frontal release signs? So these are signs that these are those primitive reflexes that re-emerge in adulthood. So remember, like I say, frontal release signs on its own is not really pathognomic for pathology, but in the presence of a dysarthria, they might reveal to an upper motor or central problem. In other words, a pseudobulbar dysarthria. So looking at the peripheral variant of a 7th nerve, in other words, those that would come in with a bulbar dysarthria, you're going to look at these features. So as I've mentioned from the brainstem lecture, these are going to all point to a lower motor neuron problem. Okay, so let's move to cranial nerve 9 and 10, the glossopharyngeal and vagus nerve. So what we're going to examine here for the pseudobulbar component is to check for the gag reflex. And in a patient with a pseudobulbar dysarthria, you're going to find a hyperactive gag reflex. So remember, this needs to be in the presence of weakness, like I say. So what's going to happen is if you examine the patient for the gag reflex, you first want to initially get that baseline. So you're first going to ask the person to open up their mouth and say, ah. If there's profound movement of the soft palate already without using your tongue spatula, that already means that the gag reflex is present. You won't be able to proceed to the next step to analyze whether it's a hyperactive gag reflex or not. It's only when you initially ask that patient to say, ah, and there's no movement of the palate, then you can proceed to to test the gag reflex. So let's quickly have a look at how it's done. It's just being repeated here. As we can see here, so there's profound elevation of that in that soft palate. So if this person had a dysarthria and you tested that, then this would have indicated an upper motor neuron finding. So looking at the Bulbar component or the Bulbar examination for cranial nerve 9 and 10, you're going to see the reverse. So instead of seeing an active gag reflex, you're going to see an absent gag reflex, and you might see uvular deviation. So that uvular deviation is really going to point to a lower motor variant or Bulbar variant of dysarthria. And finally, we're going to examine the 12th cranial nerve or the hypoglossal nerve. So while we examine the cranial nerve for that pseudobulbar effect, you're going to examine for a small spastic and slow tongue. So while I play this video clip, I want you to take note of the tongue movements, and you'll see that slow tongue movements that he has, and as well as that harsh voice that is coming out as well while he tries to articulate.
Stick out your tongue all the way out. You go back and forth. Okay. Put it back in and say la 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 la. La 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 la. Say pa pa pa. Pa pa pa. Stick out your tongue.
Now we're going to examine for that bulbar effect in a patient with a dysarthria. So what we're going to look here is you're going to look at the tongue. You're going to examine the tongue specifically in the resting position. So you're going to ask the person to open up their mouths, but their tongue needs to be inside the mouth, not outside. So protruding the tongue, you're cheating a little bit. But obviously for the sake of this video, I needed this patient to stick out her tongue. So while you examine the tongue, you're going to look for those grooves and folds, which indicates atrophy, and there might also be florid fasciculations. So let me play this video so that you can see the fasciculations happening. It really gives a little bit of a bag of worm appearance almost, these fasciculations, the florid fasciculations that we see. And now that is in keeping with a lower motor tongue. Great. So that concludes the second step, examining the patient. So remember, the first step, you're going to listen to your patient. The second step, we're going to examine the patient. Now we're moving on to the third step, the neurological signs that accompanies the dysarthria. So what we're basically going to do here is to examine for your upper motor neuron signs or your lower motor neuron signs that you're going to pick up on your general neurological examination. So you can have spasticity, your hyperreflexia. Remember, this is coupled together with weakness, might be associated slowness, and even the presence of pathological reflexes. So all of these signs are going to put some upper motor neuron findings, and that might help you to assess whether this is now a pseudobulbar dysarthria or a bulbar dysarthria. And then the reverse is true for lower motor neuron signs. But it's really important not to skip over step 1 and 2, because with step 1 and 2, you might pick up these upper motor neuron findings on the clinical examination, but you might completely miss in step 2 that lower motor neuron findings on your examination of the cranial nerves that governs articulation and phonation. So you might miss that florid tongue fasciculations, because the presence of that tongue fasciculations with these upper motor neuron findings will give you a mixed picture, and therefore the diagnosis would be then in keeping with something like motor neuron disease. So let's look at some of the typical causes for the different types of dysarthria. I'm first going to start with spastic dysarthria, which is the upper motor neuron variant. So these are the clinical characteristics of each of these. And the causes of this can typically be strokes, but then if it is a stroke, you typically want bilateral infarcts, because you want both of those cortical bulbar tracts to be knocked out that comes in from both hemispheres. There is a variant where you have a unilateral infarct, specifically in the genu of the internal capsule, that can cause a specific syndrome, but this is much more rarer. Neurodegenerative conditions like primary lateral sclerosis, as well as progressive supranuclear palsy, which is a variant of Parkinson's plus, can also present with a dysarthria. So like I mentioned, you typically have to have bilateral lesions in the cortex or cortical bulbar tracts that causes a spastic dysarthria. But there is a unilateral variant that is less severe and can be seen with an infarct. But like I say, this is a rarer variant. So what about the flaccid or lower motor neuron variant of dysarthria? So again, we see the clinical characteristics here, and this is typically caused by brainstem strokes. So in other words, it needs to hit that nucleus or the fascicle in the brainstem, or you can see it with patients with neuromuscular junction disorders like myasthenia gravis. Other diseases that can cause a bulbar dysarthria would be myositis. You can also have a mixed picture or a low motor neuron predominant variant of motor neuron disease, and that's referred to as primary muscular atrophy. And then also it can be seen in Kennedy's disease. And then for the mixed dysarthrias, you have that mixed of upper and lower motor neuron findings. And the disease that's going to cause this is predominantly going to be ALS or motor neuron disease, amyotrophic lateral sclerosis. There can be multiple strokes, but then you want those strokes to happen in the cortex or the cortical hemispheres, and then also in the brainstem as well. Multiple sclerosis can also have a mix of this because you have those demyelinating plaques that can cause breakdown of the brain tissue, and that should be either in the upper motor neuron pits, in other words, in the patient's hemispheres, as well as in the brainstem, and that will give you that mixed picture. So ataxic dysarthria is the next dysarthria that I'm going to discuss, and this typically localizes to the cerebellum. So these are some of the auditory signs that you can pick up with this type of dysarthria, and some of the common causes would be something like strokes, but then in patients who subsequently had a cerebellar stroke, it needs to be multivascular. In other words, it needs to affect both of the cerebellar hemispheres to cause a dysarthria. And then you also have some degenerative conditions like multisystems atrophy, a variant of one of the Parkinson plus syndromes that can cause this type of dysarthria. So this dysarthria is, like I mentioned before, it's got a slow cadence of speech with excessively equal stress on every syllabus. There's also the patients have scanning speech where there's irregular breakdowns of speech with explosions of the syllabi interpreted by pauses. So other causes that we can see with this type of dysarthria would be something like multiple sclerosis, because this is a condition that typically causes demyelination and then affects the cerebellar hemispheres quite early on in the disease. So the final variant of dysarthria that I want to discuss is the hypokinetic variant of dysarthria. And this typically localizes to the basal ganglia. So the auditory findings that you find in these patients are patients with a speech pattern that's decreased in loudness. Therefore, they have this monotonous speech pattern. It doesn't show a lot of fluctuations in between, and they've got profound aprosody. In other words, they lose their musical intuition. They have a slow speaking rate, and there's obviously occasional consonant errors as well. So diseases that commonly causes this would be something like Parkinson's disease. So I've included a video auditory clip for you so that you can listen to this.
Other times, I tell you out of my future to get into a baby boy. Everybody going to figure it out. And you know, we had this program now whereby we need help. People call it private. I call them. They were there in less than 5 minutes.
Yeah, sure. You say patika, 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 patika. Patika, patika, patika. Keep going. Patika, patika.
So as you can hear here, that it feels like you have to put your ear closer to the speaker to listen to what they're saying. And this is typical for this variant of dysarthria, is to have that associated findings. Great, and that brings us to the end of dysarthrias. I hope you learned something, and just remember you have to go through those 3 steps that I mentioned. So you're first going to listen to your patient, and then you're going to examine the cranial nerves that governs articulation and phonation, In other words, you're going to examine that cranial nerve 5, 7, 19, and 12. And then lastly, you're going to examine for the neurological findings that accompanies the dysarthria.